Right. Our very last speaker is Alan Kinina from Prime Health Initiative Tanzania. And Alan going to talk about the impact of group antenatal care on provision of prenatal services in Geita, Tanzania. Thank you.
Thank you. So my presentation, have background. We have a short video on the project summary, materials and the methods, the lesson learned, and this will mark the end of my presentation. So in Tanzania, where this project was implemented, about 90% of pregnant women attend at least one antenatal care visit, but only 65% attend 4 or more visits. And we know that low frequency and quality of antenatal care services are associated with low facility-based deliveries, a major contributing factor to maternal and neonatal mortality. And according to the World Health Organization, about every 2 minutes, a woman dies due to pregnancy or childbirth. And in Tanzania, maternal mortality is almost 104 per 100,000 live births. So maternal mortality is a major issue in maternal and childbirth. And the World Health Organization recommended that each woman should attend at least 8 ANC contacts. So various approaches and strategies have been implemented in Tanzania in order to ensure high coverage of ANC visits, including implementation of the group antenatal care model. And this is the key ideas of this project or presentation. So what is group antenatal care? Group antenatal care is a service delivery model where women with pregnancies of similar gestational age are brought together for ANC, incorporating information sharing, peer support, and individual clinical consultations. And this project was funded by the Bill and Melinda Gates Foundation and was named Mlinde Mama. This is a Swahili phrase which means protect a woman. In this presentation, we are sharing the findings on how group antenatal care model improved provision of ANC services in low resource settings, particularly in Geita, which is a district in Tanzania. And I will show you a short summary of the 2 minutes video showing how we implemented this project. I think there is issues with sound.
We may not be able to fix that.
Okay.
Since presenting from the laptop, so.
That is fine.
Sorry.
So this video was showing that this project had 2 components. We had a group antenatal care component and we have a machine learning part. Unfortunately, the video is not clear, but I will focus on the group antenatal care part. And luckily, we have my fellow project manager who was leading the machine learning part, and he will have a presentation tomorrow. So I hope he will link group antenatal care with machine learning. So I'll continue to my presentation. Thank you. So as I have said, that group antenatal care is a service delivery model where women with pregnancies of similar gestational age are grouped together for sharing information during pregnancy, peer support, and individual clinical consultations. And so this was an implementation study involving both quantitative and qualitative methods. And we had 6 facilities that were selected purposefully for this, for implementing this model. And we had hospitals, 2 hospitals, 2 health centers, and 2 dispensary level facilities. And pregnant women with similar gestational age attending ANC at those selected facilities were invited to form a group consisting of 8 to 15 women. So, which means each cohort had 8 to 15 women. So, after 20 weeks of gestation, these women engaged in a series of 5 meetings spaced at an interval of 2 to 2 weeks apart. And meetings were facilitated by 1 or 2 healthcare providers, depending on the availability of staff on a particular health facility. And as we see on that picture, we used interactive approaches such as small group work, games, songs, and illustration cards in order to engage these women in discussion or in learning. So women, during group sessions, women were divided in small groups to conduct self-assessment, as we see, using digital devices, mostly blood pressure machines, thermometers, and weight scales, those simple equipment that can be used by a woman. And as I've said earlier, that a provider was in between these groups facilitating each meeting. So the provider also was responsible to collect the information of each woman for follow-up, and the provider was giving reminders to these women in order to ensure that they attend each appointment as planned. So the results. We are presenting these results in a simple language that every person can understand, but there is a lot of statistical processing of the data. But we recruited about 5,900 women in about 521 cohorts or groups. So we observed that these bars, the blue bar shows that it is the baseline data. Before implementing this project, we conducted the baseline and we had some results. And the green one shows the result after implementing the group antenatal care model. So before, in Gator region, the women who were attending at least 4 antenatal care visits was 34%. But after implementing the group antenatal care model, about 95.3 women were attending at least 4 ANC visits. And So the baseline data was conducted, collecting the data in 2021 to 2022, and we started implementing this project from January 2023 to August 2024, so about 2 years. And we observed that the uptake of intermittent preventive treatment during pregnancy, this is a prophylaxis for malaria, as we know that Sub-Saharan Africa, we have a burden in malaria, so this is a key indicator in maternal and newborn health, increased from 46% during the baseline to 76% after introduction of this model. And women being monitored for blood pressure as recommended improved to 100%. And I should explain this, that as we see during group antenatal care, each woman take blood pressure or measure blood pressure during the group session. So there is no way that a woman can leave the health facility before taking a blood pressure measurement. And health facility-based deliveries increased from 87% to 97%. And as I have said earlier, that there is a lot of statistical analysis, but as I've said, that the project completed in August 2024. So we still have other women who are still continuing with the group care. That means they have not given birth yet. The lesson learned, we learned that group antenatal care increase women empowerment. And pregnant women, this was reported by the pregnant women reporting a preference of group ANC compared to the routine ANC, because group ANC promotes social connectedness and active engagement during group sessions. And group antenatal care has potential to address the significant challenges faced by healthcare systems, especially Group antenatal care has potential to address the significant challenges faced by healthcare systems, especially in resource-constrained settings, by consolidating ANC visits into group sessions, which means it optimizes the use of limited healthcare resources, such as staffing and facilities. But also, group antenatal care hold a great promise for improving maternal and child health outcomes through leveraging the advantages of peer support, as we have said that it improved the blood pressure monitoring, focused health education, as we have seen that group antenatal care involves women with similar gestational age. That means when you are planning your education session, you will focus on health education that focus only on that particular gestation. And it can increase efficiency use of resources, because a group of women can be facilitated by 1 to 2 healthcare providers, compared to routine ANC, where you should have a lot of staff. But this model has potential to enhance access to quality ANC services and contribute to healthier pregnancies and childbirth experiences, as evidenced by the result that we have seen in the last slide. Group antenatal care is still a new study. Actually, it started in the United States of America. It was called Centering Pregnancies, and later they started conducting studies and pilot studies in low and middle income countries. They tested this model in Nigeria, Kenya, and Ghana as well. So still we need more research in order to find the recommendation for the WHO and other stakeholders in order to give more evidence for them to adopt this model or for scaling up this model. So we have acknowledgement to the BMGF, our main funder of this project, the Tanzania Ministry of Health. We used the Ministry of Health platforms, and my colleague, Dr. Isaac, will talk more about that during the presentation on the impact of group antenatal care on machine learning part, and healthcare providers, supervisors, and everyone who contributed on success of this project. Thank you
so much. Thank you for this great presentation. Any questions for Alan?
Hi, this was a great presentation. Thank you very much. I might have missed this, so it's just sort of maybe more of a clarifying question, but I'm curious about how the cohorts were formed or organized.
Thank you. Okay. We had some eligibility criteria to join the court, and as we have said in the presentation, that the first criteria was that a woman who attended at least one ANC, one antenatal care visit before 20 weeks, because they started the meetings after reaching 20 weeks. So a woman who attended ANC for the first time with above 20 weeks did not engage in this court. Other criteria were the willingness of the woman to join the group, and we didn't segregate any women depending on any other issues like geographical area or yeah.
Before my question, I really want to say this is such a powerful study, like a very powerful intervention. And I wonder if you can go back to your slide where you show like the increase of like these indicators. Yeah, one more slide back. Yes, this one. So it's like these aggregate changes, like percentage of these women having for instance, 4+ ANC visits to 95%, right? Did you also look into the individual level changes, like whether a woman participate in these ANC activities? They are all very like what is a percentage of women who changed all of these like 1, 2, 3, 4 behaviors for individual women, if that makes sense?
Yes,
this is my question.
It makes sense.
Yeah, thank you.
Yes, actually we have, I can say that we have individual data showing we have the individual level data, but the data that I'm showing here is the aggregate data. Yes.
I think you probably already have the data, but that can actually help you to also calculate, for instance, like percentage of women who change all of the 4 behaviors you're looking at here. But yeah, I think this is a very small question.
Yeah, is a good observation, although maybe it can be a recommendation for future research, because pregnancy takes more than 2 years. So a woman can have 4 visits in this pregnancy, but in future pregnancy can have less or more. So maybe future researchers can form some kind of cohorts to do follow-up for one individual woman. I think it's a good observation.
Okay, thank you very much for the great presentation. Mine is, I think, is a comment. I would also like to tie your study with the previous presenter. And my comment or question or concern would be, as we continue to do these studies on maternal health, how are we also ensuring that we are involving the men? And how can the men continually be part of these studies also? Because I believe in the world that we live in, yes, it is said that there's a lot of patriarchal things, but indeed we need to shift a lot of things. And I believe also when we include the men through this journey of the maternal health care and everything, because it's not only the women who, bear the children alone. It's the men and women are all involved. So maybe for future studies, I don't know if there are studies that have also included the men in the maternal health, but I believe it can be a very important thing to also ensure that the men are taking active role in these things for also sustainability. Thank you. I think it's a comment.
Yeah, thank you. It's a good comment.
Yeah, thank you for the great job. I was just speaking on what she said on sustainability. What is the plan to sustain the intervention after the fund finishes? Because I think that's part of the issue we have in Africa. When you have these funds, after the funding, the whole program just ends. So did you think about sustainability? Thank you.
Thank you. Is a very good question. Actually, we thought about the sustainability and we involved a lot of stakeholders, especially the government, to ensure that the project is the government-owned project. And as I'm presenting this presentation, these 6 facilities that implemented this project are continuing with group ANC sessions. Although there are still some discussions because there is issues of policies, because the national policies is focusing on individual ANC model. But for these facilities, we had permissions from the authorities. They are continuing with group ANC because one more point, group ANC utilize minimal resources compared to routine ANC. Like I said, that we don't need a lot of money to implement groups compared to routine ANC.
Well, this is super interesting. Thank you so much for the presentation. So I guess 2 questions. One is, this could be a great way to also screen high-risk pregnant women as well, potentially, right? So I wonder, for those who, for example, are in this, to what extent you can then connect, or refer them to, individual ANC down the road where, maybe, through the BP monitoring, you can identify, women with pregnancy-induced hypertension, for example, or, trying to figure out whether there are other things you can perhaps see here. So whether, there may be a way to also use this as a screening tool to potentially link with, sort of a higher level care as needed. And the other question I have is, to what extent you can look at the data and figure out your eligibility criteria, which is, attend at least 1 ANC in the first 20 weeks of gestational age is highly selective. A lot of women who are really in need of antenatal care probably fall in the category of not being able to access ANC care within the first 20 weeks. And I wonder how this could be, maybe even more beneficial among those women who, are not able to, attend ANC in the first 20 weeks, but, maybe also try another version of this among those who are even less privileged in that sense. Thank you.
Yeah, thank you for your good comments, but I guess you are in IDM Symposium Committee. Maybe you saw somewhere another presentation. It's just a joke, but the main objective of this project, as I have said, we had 2 components, machine learning part and group ANC part. And the aim of machine learning part was to collect the quality data to design a predictive model for which is able to predict hypertensive disorders during pregnancy. And if you see 100% of women were monitored for blood pressure as recommended, which means no woman missed blood pressure monitoring compared to the routinians. We are talking about the low resource settings where in some facilities there is no even a blood pressure machine. And my colleague will present the results because we have already designed that model, which is able to predict the hypertensive disorders during pregnancies. And there is a lot of things to talk about what we observed in group care, including clear monitoring of risky pregnancies. Yeah, including that hypertensive disorders. And we take that comment for during scale up, we plan that we will consider all women from 4 weeks and above.
Hello. Yeah, this is super exciting to see just like how successful the implementation of this was. I was curious if you had analyzed or had access to data on kind of like further down the maternal and neonatal outcomes associated, whether you were able to see like improvements in, for example, like reduction in maternal complications or like kind of related to like, screening, so you're able to transfer high-risk mothers. If you had looked at any of those components to like safe and healthy delivery.
Thank you. That is a good question. And I would like to welcome my colleague, Dr. Isaac, to answer that question because he was the one who was playing with each data from the individual to aggregates.
Yep, thank you. Very good question. Yes, part of the challenge in this type of implementation is data. And there were not very good quality data, and we missed a lot of outcome data. So we had to arithmetically calculate the outcome indicators and not using the observed findings from the data itself. Thank you.
Thank you.
Thank you so much. Let's thank our speakers one more time.